setting this up. I'm Ashley, for those of you who don't know me. I'm obviously newer on the team. You okay?
That's okay.
Okay.
Is there a doctor in the house?
I've been here for about a year and a half, and obviously I've learned a ton from Dr. Kirkwood, Dr. DeVar, and Melissa has been probably the biggest one too, helping me to learn all these things. So I'll talk about how do you know your treatment is working. These are obviously general guidelines. Every person is different. Everyone responds to their treatments differently. But these are kind of general guidelines, and I'll go through some of the ways that you can help yourself to know, but then you can always just ask us if we think it's working too. So I'll start off with defining the types of treatment that we have. So there's two main categories. One is what we call adjuvant, and that's essentially preventative. So these are people that have a stage 2B, 3, and stage 4 that has been taken out, those stages of disease. So they don't currently have any evidence of melanoma in their body, but we are doing this treatment to prevent it from coming back, because people with these stages of disease have a high risk that it can come back, and we obviously don't want that. So that's the first category, and then obviously the second is treating metastatic disease. So that is in people with stage 4 disease. There are known areas of melanoma in the body that has spread from where it first started, and it is now distant. We want to shrink the tumors and stop the spread of disease and obviously slow it down. So some of the treatments, obviously, they've been listed in the slides previously, but we have interferon, ipilimumab, nivolumab, pembrolizumab, dabrafenib, trametinib. TVEC is one of the injections, and obviously the clinical trials, which consist of a lot of different treatments there too. Just a quick touch to stage 1 and earlier stage 2A disease. Those are people that have surgery, and that's pretty much it. They don't actually have treatment. That is because the risk of it coming back is not high enough to do treatment. So in case you have that and you're like, why am I not included in this? That's why. So these are the two main categories that we have. So this is just kind of the agenda. This is what I'll run through with each of them. Adjuvant treatment, we have a couple different kind of ways that we watch to know if the treatment's working. And then metastatic is a little bit more basic. You're going to get scans because we need to look at those tumors. We need to see everything. So with adjuvant treatment, we always get labs for everyone. So a lot of these are mostly to monitor for side effects. And like Melissa said, we'll pick up on a lot of the side effects from the labs before you notice anything. So the couple ones that we always draw is the CBC, that stands for complete blood count. That's your red blood cells, your white blood cells, platelets, all that. So that's kind of just keeping an eye on everything there. The CMP stands for comprehensive metabolic panel. That tests your kidney functions, your liver functions, electrolytes, kind of keeping an eye on all those things, making sure nothing's going too out of whack that we need to worry about. The LDH is obviously a big one that a lot of people know about, a lot of people ask about. That stands for lactate dehydrogenase. And that is our best, what you can call a tumor marker for melanoma. So it's not definitive, it's not specific for melanoma, but it does help us to know if that jumps up all of a sudden, then we kind of get worried. Do we need to check into things more? Is there something going on? Because that's a level that in people that have metastatic disease tends to be higher. But again, it's not specific for melanoma. We're still trying to find a good blood marker that we can watch. And then we also check the thyroid function, and that's because a lot of our treatments can affect the thyroid function. Just the picture I have as an example, CMP, some of the stuff that we check for on there. Another way that we monitor people that are getting adjuvant treatment is with a chest X-ray. It's a basic look at the lungs. The reason why we get the chest X-ray is because if melanoma is going to travel in the bloodstream, if it's doing that, 2/3 of the times it will go to the lungs, if it's going to come back. Doesn't always, obviously. But this gives us a quick, easy picture, look at the lungs, make sure there's no nodules growing there, and it also actually can help us monitor for side effects as well, like the pneumonitis, things like that. It's cheap too, so insurance will pay for it. So that helps us out. Another thing that we use for monitoring adjuvant people is an ultrasound. So this is kind of for a certain subset of patients. This is also a little bit newer of something that we watch. This is for people that have had stage 3 disease. It was found in what we call the sentinel lymph node, so that first lymph node that we test for. So melanoma was found in that one, but then we didn't check the other lymph nodes in that area. So say someone has a spot of melanoma in their arm, they check the lymph nodes in the armpit, and there's one that's positive in there. What we used to do is say, okay, we're going to go back into that armpit, take out all the lymph nodes. Now there's been papers published, and they feel that taking out all of the rest of those lymph nodes actually doesn't really help prevent much disease, and it can cause a lot of side effects as far as swelling of the arm or leg, wherever it came from. So they're not taking out all those lymph nodes, so we need to watch those and make sure that melanoma is not coming back there. So we do that with an ultrasound. And so we can look, this is kind of an example of what it looks like. There's the normal other soft tissues around it is the grayish stuff, and then the lymph nodes are a little bit more solid, so they're black. And so, we can watch those, we can measure them and say, is this growing? Do we need to be worried that there's melanoma in those lymph nodes? So again, it's for certain subsets of patients, and obviously we'll discuss that if you fit into that category with you. The good thing is it's non-invasive, no radiation, again, cheap, insurance loves to pay for it, so, well, they don't love to pay for anything, but. So another way we can monitor people that are getting adjuvant treatment is with scans. This is, again, also for certain subsets of people. Not everyone gets scans. This is for higher stages and a higher risk of it metastasizing or spreading to other places, or this is for people who did have metastatic disease and it was taken out. And those people, again, it's because they have a higher risk of it coming back because they were a higher stage. And so these are just done to ensure there's still no evidence of melanoma. It's more specific, it takes a closer look, and so it's a great tool that we have. The other thing with the scans, if we're ever worried about something on a chest X-ray or worried about something on an ultrasound, we can always get the scans. People, say they might be worried about that. We can always get those. Then follow-up appointments are obviously a great way to know that your treatment is continued working. Checking in with us, letting us get the labs, letting us get the scans, the chest X-rays, all that stuff is the best way to make sure that we're keeping an eye on things for you. So now getting into the metastatic monitoring of things, labs again. These are pretty much the same ones that we get for the adjuvant people, and the same reasons. Keep an eye on everything, check out those thyroid functions, and like Melissa said, if we are concerned about adrenal function, pituitary function, the extra ones we can always order those at any time. These are just kind of the basic ones. And then scans. So if you have known areas of tumor in your body, we gotta get scans and we gotta check it out. And so they allow us to measure tumors, and that can show us what's happening with the treatment. So you can either have a response, you can have stable disease, or you can have progression. Unfortunately, obviously does happen even when you're still on treatment. So the first picture shows what we call a complete response. Things have gone completely away. So the red arrow is pointing to a little area of tumor there next to the spleen, and then you can see in the after picture that little spot is gone. So it's completely gone. That's what we call a complete response. That's the best case. The second picture is of a spot that's in the lungs, and you can see it's larger on the left picture before treatment, and then it has shrunk on the picture on the right. And so that is what we call partial response. Things are shrinking, you are responding, but they're not completely gone. And then stable disease, obviously you can figure out what that is, things stay the same. And then the picture on the bottom is someone that had progressive disease, so there's a really tiny little nodule in the lung there on the picture on the left, and then after treatment, it's actually gotten bigger. So then, that's when we talk about switching the plan and figuring new things out. And so this allows us to measure those things, check for any new areas of tumor, because even if things are responding in one area, but there's something new in another area, then that, raises flags and we have to think about changing things. And they also help us monitor for side effects. So things like pneumonitis is very easy to see on a CT scan. That's usually the biggest one that we can check for on that. And then I also just threw up a little slide. This is like radiology 101, very brief, of the type of scans we get, because a lot of people ask, what's the difference between these? Why do you do the different ones? So the first one and the most common one that we get are CT scans, also called CAT scans. Stands for computed tomography or computed axial tomography. And these ones are the best ones for monitoring for a recurrence in people that have a high stage that don't have any evidence of melanoma, and then measuring any metastatic tumors in there. Those really allow us to see exactly where it is, pinpoint, this is the examples on this slide. We can see exactly what level of the lungs it's at, where it is, and how big it is. We actually go in with a little ruler tool on the screen, and we can measure in millimeters or centimeters. The next type of scan that we sometimes get is a PET CT scan, or just a PET scan. It stands for positron emission tomography. And that is best for initially detecting if there is metastatic spread or if you don't have any evidence of melanoma in there. And then it also is helpful in determining if a tumor is metabolically active or not. And the way it works, you can see the example picture on the bottom. They inject you with, it's essentially a type of sugar contrast, and the scan sees how your body is not digesting that, but using that up. And so things like your heart, your brain, those light up really bright because they're very active. We want those to be active. But it can also show us areas that are active that we don't want to be active, like this spot that's in the lungs. It shows that bright orange. And so that would be concerning for a spot of melanoma. It's not the best at measuring things, but it lets us know where something is, and then we can follow up, if we need to, with a CAT scan and actually measure it. And then the last type of scan that we usually get is an MRI. It stands for magnetic resonance imaging. And this is best for brain, bones, and sometimes soft tissue stuff. So we most commonly get it for the brain. As you know, melanoma can progress to the brain. And so you can see the arrow is pointing out there, a little spot of melanoma. And there's a couple different kinds. There's with contrast, without contrast. So we go through those and try to find any little spot. And again, we can measure very well with the MRIs. It also works well for bones if you have a spot in the bone, spinal cord, sometimes the soft tissue areas. This is used sometimes if people are having, we'll say shoulder pain, and we say we need to look at that a little closer and make sure there's no melanoma there. And actually, I forgot to include there too, but it's great for the liver. So if you have melanoma in the liver, the MRI is really great at looking at that and determining size if it's there. So that's just some stuff. And again, like I said, it's all kind of general guidelines. If you ever have questions if it's working, just ask us.